Right, hi. Good afternoon, everybody. Welcome to another webinar hosted by the College of General Practitioners of Sri Lanka, and this time in collaboration with the Sri Lankan College of Dermatologists. And today's webinar is very importantly about an important topic. Okay, it's about the epidemic of Tinea infections and how to manage this in primary care level. As primary care doctors, you all know that fungal infections are not scarce, right? It's abundantly encountered by primary care doctors. And Tinea infections also are commonly encountered and being treated. The problem occurs, which is relevant to our topic, when these infections are not diagnosed properly and also not treated according to the guidelines. And because of this reason, most of the antifungals have become ineffective and a lot of resistance has happened. So this is actually nothing unique to Sri Lanka. That means we are not alone. Most of the countries are facing the same problem. So the Sri Lankan College of Dermatologists together with College of General Practitioners thought that this is the duty of us to educate you all, the primary care doctors, about this epidemic sort of thing and to guide you to treat, diagnose and treat Tinea infections properly. So not only the qualified general practitioners and family physicians, but also the locum doctors, the OPD doctors in public and private sector are being targeted at this webinar. So to start this webinar, while welcoming you all again, I would like to invite Dr. Chandani Mugirwada, the president of the Sri Lanka College of Dermatologists. Dr. Chandani Mugirwada is from the National Hospital Kandy, and she is a member of the board of study in dermatology and also an examiner in MD exams in dermatology. Today she is here as the president of the College of Dermatologists and to tell you about the importance of this topic, the opening remarks. Madam, over to you.
Thank you, Dr. Sankar, for kind words of introduction. First of all, I must thank the College of General Practitioners for arranging a collaborate meeting with Sri Lanka College of Dermatologists. I also thank Glenmark Pharmaceuticals for mediating this event. Actually, as Dr. Sankar mentioned, fungal infections, especially Tinea infections, is alarmingly increasing in incidence in Sri Lanka during past few years. So we see lot of cases in all age groups, including infants. Sometimes whole family members are affected. So, and they present with multiple extensive lesions involving flexures, body, limbs, and face, almost all the areas of the skin. So this increasing in problem is mainly due to the one is misdiagnosis and also the topical application of combined preparations containing steroids. That is one main cause for that, and also the inadequate dose and the duration of the antifungal therapy. So due to these malpractices, as already Dr. Sankar mentioned, we encounter a lot of resistant cases, which is not responding to our conventional therapy. So as primary care physicians, you encounter the patient in its initial stage. So it's very important to make the correct diagnosis and give the correct treatment to prevent this worsening of this epidemic further. So one thing that if you have doubt in the diagnosis, do not hesitate to get the second opinion, and also do not prescribe steroid containing combined preparations. So Dr. Nayani Madarasinghe, as the chairman of Fungal Task Force and the main researcher of the fungal study group, is the best person to update you regarding the correct diagnosis and the correct management. Thank you.
Right. Thank you very much, madam, for those enlightening words. I think you gave the essence of today's webinar at the outset. So now we are straight away moving to our speaker. Our speaker today is Dr. Nayani Madarasinghe. Dr. Nayani Madarasinghe, MBBS, MD Dermatology, and MSc in Medical Sciences, is presently the dermatologist in the National Institute of Infectious Diseases, or the IDH, and she earned the MBBS in 2002 and the dermatology in 2010, and research MSc in Medical Sciences in Edinburgh, UK in 2011. In addition to being a dermatologist, she is a very active member in the College of Dermatologists of Sri Lanka as well, where she serves as the secretary of Sri Lanka College. She was the secretary of the Sri Lanka College of Dermatologists from 2017 to 2019, and currently as the chairperson of the Fungal Task Force and Cosmetics Committee of the Sri Lanka College of Dermatologists also. So, madam, over to you to talk about the epidemic of Tinea infections, management in primary care. Ladies and gentlemen, I have been informed by the technical team that Dr. Nayani Madarasinghe has been logged out for a second. So until that, give us a few minutes, a few seconds probably, until the technical team gets back with Dr. Nayani. Yeah, I have been informed by several people that nothing can be heard or seen because the line is not online. Just give a second.
Hello.
Yes.
Hello, sorry for the disturbances. So I don't think you heard me from the beginning, right?
You have been introduced, madam. Now you can continue.
Yes.
You can start, yeah. Start freshly, yeah.
I think I'm actually now joining from my phone. Hello. Can you hear me now? And this is okay now.
No, madam. That is showing same thing.
Hello.
Doctor, please proceed.
Okay. Yes. So I would be talking on dermatophytosis, which is a common topic, yet and simple management. Yet it is important because we are trending towards an epidemic of dermatophyte infection in Sri Lanka. And I'm actually very happy to do this lecture today because we believe that primary care physicians play an important role in managing this dermatophytosis and also in overcoming this problem of recalcitrant dermatophytosis. So at the end of my lecture, I hope that I will be able to inculcate some practice points which would be useful for you to use in the management of dermatophytosis and also which will positively contribute towards overcoming this problem of recalcitrant dermatophytosis. Can I have my slides, please? Can you put it as the, yes. So next slide, please. Yeah, so in my lecture, I will be giving an introduction and the clinical features of dermatophytosis and management, and also highlight the problem of the low therapeutic response of dermatophytosis in Sri Lanka. So talking about tinea infections, dermatophytosis, next slide, please. Talking about the tinea infections, as you know, it is a fungi which invades the keratin layers of the skin. So it is usually known as tinea infection, and the late term is the ringworm disease. And because it invades the keratin layers, it can invade both skin, hair, and nails, and cause problems in all these three areas. And talking about the classes of dermatophytosis. So next slide, please. Talking about the classes of dermatophytosis, there are three major classes like Microsporum, Trichophyton, and Epidemophyton, and these can be like both human and animal pathogens. And actually, if we classify this dermatophytosis according to the origin of these fungi, there are three main classifications. Next slide, please. That is like, it could be like zoophilic, or it could be anthropophilic or geophilic. So zoophilic is that the fungi is mostly in animals, but they can infect humans as well. Can you move on to the next slide, please? And then anthropophilic is, it is mostly found in the humans, and geophilic is, it is found in animals. So yeah, it is found in the soil. So I'm sorry, I can't move on without seeing the presentation. Yeah, next one. So the transmission, if you take the transmission of this fungal infection, the main mode of transmission is by the contact with infected animals or humans. And it can also get transmitted by airborne hair and scales, and also with fomites and soils. This part is very important because infective spores in the hair and dermal scales can remain viable for several months to years in the environment. Therefore, like the spread within the household can be curtailed by having adequate disinfectants and mechanical cleaning of the environment to get rid of these infective spores. I think now we can move on to the clinical features. Next slide. Yeah, the incubation period is usually 1 to 2 weeks, and the clinical features may vary depending on the region affected. Usually, all these lesions are pruritic, and depending on the area which is involved, the skin lesions can vary. But the hallmark of this disease is like the ring-shaped lesions. The ring-shaped lesions, which shows an active edge with papules and pustules in the periphery, and also there can be hair loss if the hair-bearing areas are affected. Next slide, please. So, as I said earlier, like these lesions could be like vary depending on the site affected. So, talking about Tinea capitis, that is the tinea infection which is occurring in hair and scalp, and this is usually seen in children. There can be areas of alopecia which is usually non-scarring, but if it is inflammatory tinea like zoophilic tinea fungi species which is involved, these lesions may be very inflamed and like form boggy masses like abscesses and may even be suppurative. And this kind of inflammatory tinea can even give rise to scarring hair loss. That's why the early intervention is necessary. And in Tinea capitis, lymph nodes may be enlarged. Next one. Then we have, yes, these are some pictures of Tinea capitis. These are the non-inflammatory teneas where you can see the scaling and like areas of hair loss, which is presenting as non-scarring alopecia. And the next one would show the scarring alopecia. Next one would show a inflammatory boggy mass resembling an abscess, which is an inflammatory tinea capitis, which is also known as a chirion. Yes, coming on to tinea corporis. Tinea corporis is when the infection affects the trunk and the extremities. Actually, this is the classical sign of tinea. Like you get these erythematous round patches which have central clearing and elevated scaly borders with papules and pustules. So we see that there is an active edge. Next one. Tinea barbae is when the tinea infection affects the beard or the beard area. And clinically, this can be difficult to differentiate sometimes with the bacterial folliculitis, because there have been both these cases, there can be scaling and follicular pustules and erythema. But if it is in Tinea barbae, there can be hair loss. These hairs which are infected with the fungi are easily plucked out. Next, if it is infecting the face, it is known as Tinea fasciae. And usually Tinea fasciae is not a very common presentation earlier. But with the resultant, like the current epidemic of fungal infection, dermatophytosis with atypical presentations, we see more and more cases of Tinea fasciae as well. The problem with Tinea fasciae is sometimes it may not be very straightforward to diagnose, and it can often be confused with other skin disorders. Next one is like the groin area. It is known as tinea cruris when it involves the groin, and like you can see the typical skin rashes with the advanced active edge. And tinea pedis is commonly known as athlete's foot. And you can see the fissures. There are different types of tinea pedis. Can I see the next slide? Actually, there are three types, like where you get these interdigital maceration and scaling, which is a common presentation, or else, can you please click again? Yes, this is the other type where you can see the erythema and scaling, and sometimes it could be just the vesicobilous appearance as well. So tinea pedis can sometimes be misdiagnosed as eczemas and sometimes be psoriasis, but usually if it is the common interdigitally type, it is very easy to diagnose. Tinea manum is when the tinea infection involves the hand. Usually one hand is affected and the palms would be dry, scaly and erythematous. Actually, erythema may not be that obvious in our type of skin, and this can occur as an extension of the athlete's foot. Tinea unguum is the tinea infection which is occurring in nails. Here the nail changes could be like thickened or discolored nail plate, and sometimes there can be subungual hyperkeratosis, that is like keratin material accumulating in between the nail plate and the nail bed. And also the nail plate can be elevated from the nail bed, which is known as onycholysis. And usually one or two fingers would be affected. Now we'll move on to the diagnosis. So tinea infections are usually diagnosed clinically because, as I mentioned earlier, if it is a typical tinea, it is not a difficult diagnosis. And I think even a medical student after the 2 weeks post the appointment of dermatology will be able to diagnose a straightforward tinea infection. But there are some instances that it could be difficult, especially when they are treated with steroids earlier. I will be coming to that later on. So in those cases, we do the skin scrapings for mycology, where you can see this fungal hyphae under the light microscope. This is usually done as a bedside test, and it is even available in most of the established dermatology clinics. And then you, for further cases, you have the tinea, the fungal cultures, which is not done as a routine examination. Can you move on? But fungal cultures are required to identify the organism. Yes. So now we will move on to the most important topic, that is the treatment. So the treatment of tinea would vary depending on the site and the extent of the disease, and also site and the extent of the disease, and also the extent of the disease, and also the patient characteristics. So you can use topical or systemic antifungals depending on the these characteristics. Can you move on, please? Yes. Topical antifungals are indicated for single lesions and tinea cruris, that is if not treated earlier with steroids, that is the naive tinea cruris, and also when systemic drugs are contraindicated. Yeah. So generally these are continued for 2 weeks post resolution. This is also important because patient tends to stop the medication once there is partial improvement or when the itching subsides. So we have to advise them that it has to be continued 2 weeks post resolution. And also how to apply the way they are applying is also important, and it has to be applied usually 2 centimeters beyond the active margin. Then talking about which antifungal, actually there's no hard and fast rule of which topical antifungal to be used. It is variable. Azos are generally considered as the first line of the topical antifungal, but then we have the other topicals like terbinafine, amlodipine as well. This may be variable depending on the personal experience and also location and the severity of the infection. Then we will move on to the systemic antifungals. So most of the time, systemic antifungals are needed, especially in the today's scenario where the lesions are very extensive, infections are very extensive and chronic. So anyway, tinea capitis, because it is a deep infection involving the hair follicles, systemic antifungals are needed. And tinea pedis, onychomycosis, extensive tinea corporis, and also tinea incognito. Tinea incognito is the name given when the tinea infection is treated with steroids earlier. I will be talking about that in detail later. Next one, please. So then the biggest dilemma, which oral antifungal to use. Again, there is no hard and fast rule. The recent guidelines from Indian Dermatology Association, we don't have Sri Lankan guidelines, but we are having a similar situation to India, less severe. And they have like formulated a recent guideline, and there they have suggested either itraconazole or terbinafine as a first-line treatment in naive and chronic tinea infection. But I think you must be aware that we don't have a continuous supply of itraconazole in the government sector. So in our case, like we tend to give prisofulvine as well. Then what about fluconazole? I think you must be knowing that fluconazole is widely practiced, especially among the primary care physicians and sometimes by dermatologists as well. But it is usually not considered as effective for dermatophytosis. There are few studies which have showed that efficacy of fluconazole with 50 or 100 milligrams per daily dose, but not the 150 milligrams weekly dose, which is commonly practiced. And the problem of giving fluconazole for dermatophytosis is actually this is the biggest fear that the mycologists are having in Sri Lanka, that it can cause resistant strains of candidiasis to develop. So reserve your fluconazole to treat candida infections, not dermatophyte infection. Next one, yes. Then about the dose and the duration. Again, these two will depend on the site of the infection. Usually, if it is a terbinafine, we give a 200 milligram once daily dose, and itraconazole can be given for 100 to 200 milligrams per day in naive cases. Actually, like some time back, the guidelines were like to give these drugs for 1 to 2 weeks. But the recent Indian guidelines suggest a minimum of 2 to 4 weeks, mostly like 2 weeks, and then depending on the response, we can increase. And if it is a tinea incognito, longer durations of oral antifungals are needed, which can even go up to 4 to 6 weeks or even more. Then, so as you know, antifungals are not without problem. So one is hepatotoxicity, which is more with itraconazole, and terbinafine is the least hepatotoxic drug out of these. And also they can have a lot of drug interactions, and especially with the increasing prevalence of fatty liver, giving these drugs for longer periods is becoming sometimes a problem in our day-to-day practice. So this has to be done in cautiously in people with other complications. Moving on to the management of tinea capitis, this is also very important because mostly it is the children, and here the drug of choice is actually prisofulvine, and it is given in a dose of 10 to 20 milligrams per kg. And because we have to treat the hair follicles, we have to give systemic medication. And especially if it is a chirion, which has a tendency for scarring alopecia, it is very important that we intervene early. And sometimes there are instances that we see chirions are treated with incision and drainage, thinking that it is an abscess, and that will leave a large raw area as well as delaying in treatment, which will give rise to permanent scarring alopecia. So if it is an inflammatory tinea capitis, start your treatment early because you will be preventing scarring alopecia. Next one. Treatment of onychomycosis. This again, we see so many instances that topical treatments are given. But topical treatments are effective only if it is limited involvement or superficial onychomycosis. And we have to give oral antifungals, usually itraconazole or terbinafine. And this can be given as a continuous dosages or as a pulse therapy. And the problem with the treatment of onychomycosis is one is that they are having a lot of clinical mimics. which are very different from the therapeutic management of strategies. Like if it is a like psoriasis, the management would be totally different from that of dermatosis. So we have to be do a proper diagnosis. And even though we do a proper diagnosis, these antifungal drugs have to be continued for a longer period. And sometimes it is difficult to achieve 100% clinical cure. And also, even if you get a cure, there is a high relapse rate. So treatment of onychomycosis is again difficult. Yeah, we have now come to the end, like the last part of my presentation, that is the recent scenario of dermatitis. So as we mentioned earlier, for the last 2 to 3 years, actually this has been seen in a big way in India, the Southeast Asia, for over the last 4 to 5 years. But we tend to see last 2 to 3 years, there's an increasing incidence of dermatosis occurring in Sri Lanka. And then there are, next slide please, there are extensive disease. Next one. The disease is more extensive and with atypical presentation. Can you move on? And then the next one. Next slide, please. Next one is like, that is the most important problem, because like we see, actually, as I mentioned earlier, tinea was a common disease which was easy to treat. And like we dermatologists are most of the time teased for not having cures for our dermatological illnesses. But like few years back, tinea was something that we were able to offer a cure. But the things have changed nowadays, and we see quite a lot of inadequate therapeutic response, which has led to chronicity of the diseases and also recurrences. Sometimes we see that the management of dermatophytosis is even becoming quite a challenge as we are managing other chronic skin conditions like psoriasis or vitiligo. Next one, please. So actually confirming what I said earlier, like there was a study which was done in 2019 with an online survey of 50 dermatologists, and 80% of them believe that there's a lack of therapeutic response to standard antifungal agents. The important thing here is that it's not like antibiotic resistance. Antibiotics, we have plenty to choose from, and like we can step up the ladder if one is not sensitive. But when we talk about antifungals, both for superficial fungal infections as well as invasive fungal infections, we have only few drugs which can even be, which is just that we can even name. And then the problem is like there can be cross resistance also. So this is, I think, like we have to be really concerned about this emerging problem of lack of therapeutic response in dermatophytosis, because it may not affect dermatophytosis alone, but in time to come, if there is also resistance, that can even affect the systemic fungal infections as well. Next one. So the other thing is that we may be seeing just the tip of the iceberg of this problem, and the problem may be more severe, and even you at the primary care level may be encountering this problem in a severe way. So the next, I think it's very important that we identify the contributory factors for this therapeutic failure. Why is that important? That is because like there are some modifiable factors which by spending few minutes, extra minutes with the patient, or just by a small change in your practice pattern, that we can do a huge change in this therapeutic response in dermatophytosis. So usually it is a multifactorial contributory factors, like it could be host-related factors, fungi-related factors, environmental factors, or it could be drugs. Next one, please. Next one. So talking about drug-related factors, drug resistance is number one. Actually, we haven't recorded drug resistance in Sri Lanka, but resistance to both itraconazole and terbinafine is reported in India. So we think that we may be having a similar tendency, and actually we are having an antifungal sensitivity study which is underway. So we may get to know the results soon. And also like improper dosages and duration of the treatment. This may give rise to a lack of therapeutic response, as well as this can give rise to drug resistance. And then the other thing is the biofilm. So as per the biofilm in bacteria, there's a fungal biofilm which is occurring, which can reduce the penetration of these antifungal agents. And then low quality drugs. This again is a problem, is a huge problem in India, where they have so many brands of these antifungals available. We have only few brands available in Sri Lanka, but still there can be quality differences of the drugs. So that is also important. And then the drug interactions, because especially itraconazole, it is known to have a lot of drug interactions with commonly used drugs, even like things like omeprazole. So although they are given in the proper dosages, the patients may not be achieving the desired therapeutic blood level of the drug. So the therapeutic response may be low. And then the most important factor, one of the other important factors is the poor compliance. So poor compliance comes with lack of education and also due to the high price of these drugs, because most of the time these drugs are not available in the government sector, and we have to give them in the from ask patients to buy it from private sector. And when more than one person is affected within a family, I think, and the drugs is given for a few weeks, I think you can imagine the cost of the drugs the patients have to bear. So it is not surprising that they tend to stop the medication once they have some amount of clinical response. Next one. Yeah. The other one is the fungi related factors. So again, the resistant strains could be developing. So one cause for the resistant strains is like inadequate dosages of the antifungals, and also the high usage of fungicides as pesticides in the agricultural industry is again postulated as one of the main causes for the resistance seen in antifungal drugs. And then the other important thing is the change of predominant fungal species. Actually, we have done a multi-center study in Sri Lanka, and there also we have seen that the predominant fungal species in Sri Lanka is Trichophyton mentogrophytes now, which was Trichophyton rubrum earlier. Actually, this is a trend seen in the Southeast Asia, and we are just following it. And Trichophyton mentogrophyte is known to be a more virulent organism, giving rise to more inflammatory clinical features. So this could be another cause why that we see a lot of like extensive fungal infections which are less responsive to treatment. Next one. Then we have the host-related factors. Immunosuppression is one of the leading causes. So as you know, there are so many patients who are diabetic, and then people who have undergone renal transplants, and like patients on chemotherapy drugs. So all these patients may be acting as the focus of infection. When they get the disease, they tend to have the disease in more severe way and also more persistently. So they may be giving the disease to the others in the household. And additionally, there can be a local immunosuppression because of the inadvertently used steroids for the Tinea infection. Then things like poor hygiene, change of fashion sense. We see quite a lot of youngsters using these tight-fitting jeans and like synthetic undergarments, which can cause this increased sweating in these folds and flexures, which will give a good environment for the fungi to grow. And also having household contact will increase the chances of having the infection. The next one is actually the environmental factors. That could be the hot humid climate. Next slide, please. And also like overcrowding, like these could be other factors which is coming from the environment. So knowing all these factors, then we can just think like what are the modifiable factors of these that we can intervene, and like if we change this, there can be a there will be a turning point in this management of dermatophyte infections in Sri Lanka. Next slide, please. Yeah, the next one. Next one, yes. So here I would be just touching on some of the mistakes that we see is being done in the primary care level and sometimes even at other levels. So one is mainly the inadequate communication with the patient. So when you get a tinea infection, patient with tinea infection, actually with this problem, I personally have increased my time spent with the patient with a tinea infection because we have to give them some extra bit of information. So we have to inform about the drug, how to apply the drug and how to take the drug, like if it is a itraconazole, that it is important that it is taken after meals and if possible with some acidic fluid like lime juice to increase the bioavailability. Can you please move on? And then we have to specially advise them that these drugs should be continued for the prescribed period because they tend to stop when they achieve the symptomatic control. And about, we have to ask from the history what are the other drugs they are on and to see of possible drug interaction. And then the treating of household, all the household contacts at the same time is also very important. And some bits about personal hygiene, like keeping these areas clean and dry, and like washing their clothes separately, possibly in like better if it is in hot water, and dried in direct sunlight and ironed. And also the disinfection methods. Like as I mentioned earlier, these fungal scales can be viable in the environment for many, many months. Therefore, like mopping and cleaning surfaces with the normal disinfectant would get rid of this fungi, and also mechanical removal by vacuum is also good if possible. And then like they should not be sharing their clothes or any of the personal items. So this bit of information should go into the patient by spending a little more time with the patient. Next one. The next mistake that we see is not giving the proper antifungal drug. Next slide, please. So I mentioned earlier that terbinafine, itraconazole, and are the most commonly indicated drugs for typhoid infection and tinea infections. And then like we can use cruciferine also. But here is the other section of this online survey which was conducted in 2019. And you can see that both in the private sector and government sector, the fluconazole was the most preferred drug by the primary care physician. Actually, this was a study which was done among 54 primary care physicians in the Western province. Next one. Next slide. So the other one is the inadequate dosages and durations of the antifungal drug. So by giving inadequate dosages and durations of the drug, it can cause partial clearance and it can spread within the household contacts and recurrences can occur, and also it can give rise to drug resistance. Next. So this is one of the most important factors and most important mistakes that we see. That is the use of topical steroids in the treatment of dermatophyte infections. So this is actually like our patients have the habit of keeping all these empty tubes and the boxes. So it is sometimes useful. This is the patient who came with a dermatophyte infection, and you can see he was given even the highest potent steroid here. Next slide, please. So steroids can cause a localized reduction of T-cell mediated immunity and reduce host mediated inflammation. Thus, it can cause ineffective elimination of the dermatophyte, giving rise to chronic and widespread and difficult to treat lesions. So it's not only that. Steroids will reduce the inflammation and give rise to a lot of atypical presentations. You can see sometimes it is difficult to diagnose, even if it is just a tinea. Sometimes when they are treated with steroids, the diagnosis can be more difficult. So these are like two rings occurring within the same tinea lesion, and it's a special phenomenon. And also you can see the hypopigmentation which has occurred in the fingers, which has occurred as a side effect of steroids. Next one. So in summary, steroids can alter presentation. So this is difficult. Like, please move on. So, and in summary, like it can alter the clinical presentation and it can reduce the scaling. So even if you want to do a diagnostic test, it is difficult to obtain skin scales for the fungal microscopy and culture. And then lastly, it would cause the fungi to go more deep into the hair follicles, and the treatment is going to be difficult, and longer durations of antifungals are needed when the dermatophyte infection is previously treated with steroids. So although this topical steroid is having this much of harm in dermatophyte infection, but we see some unfortunate results. Like next one, please. Next slide, please. We see some unfortunate results. Like you can see that this was a multi-center study which was with representation from all 9 provinces in Sri Lanka. And here, like almost 45% of the patients gave a history of having a topical steroid. And if we take the history plus the examination findings of prior usage of Tinea, it goes even up to 60%. And then we looked at the source of this topical steroid. So one thing, although it is a prescribed medicine, the patients can get it over the counter from pharmacies or by self-medication. But what we saw, the results we saw was even more disheartening. Can you move on to the next slide? The highest percentage of the steroid prescriptions has come from the hospital OPD itself, and then the next one was from the general practitioners. So I think this is one reason, this is actually one of the major reasons that from the Sri Lanka College of Dermatologists that we thought that we have to take this in a big way, and like we have to take measures to educate the primary care physicians, because just by this adding a topical steroid, and this problem can become even worse. And the other reason is why, and other problem is why this topical steroid is added. So sometimes, actually, some time back, it was believed that by giving a topical steroid in the initial phase of Tinea infection, like maybe for 1 week, the inflammation will reduce, and also it will cause better penetration of the drug. But this sort of thinking is no more, and steroids are not indicated at any time in treatment of Tinea infection. But most of the time what we see is when the diagnosis is not sure, people are given a topical steroid. So what I would say is, like, if you are not sure of the diagnosis, just give some good antihistamines so that the patients are not symptomatic, and get down the patient in 3 to 4 days. So Tinea will evolve, and then you will be sure to diagnose it, because it's not a complex diagnosis. So if you get down the patient in maybe in 1 week's time with good antihistamines, you will be able to diagnose it. So if you are not sure of the diagnosis, don't give a steroid, just antihistamines or even a topical antifungal, and then get down the patient again without giving a steroid. So, and like from that, and also there was a biggest problem with the triple and double combinations of these topical steroids and antifungal preparations. And Sri Lanka College of Dermatologists actually requested the NMRA, and we were so happy to see that the new registrations of all triple combinations were banned from February 2020. And also the NMRA further extended this, and they have taken measures to ease out the order. Move on to the next slide, please.
Doctor, please continue.
Yeah, can you move on the slides, please? Yeah, next one. So this is the like to measures to ease out the existing triple combinations as well. So like I would say like the steroid, topical steroids in any form at any stage of dermatophytosis is a definite no. Can you move on to the next slide? Yeah, move on. Yeah, so I'm happy that we have come to the last one, that this is the last mistake, that is not doing timely referral. So can you move on? So if I think it's better to refer to a specialist if it is a chronic dermatophytosis, recurrent disease, poor responders, and extensive tinea purpuris, and also with patients with hepatic and patients with immunosuppression. So finally, my take-home message is that recalcitrant dermatophytosis is going to be an important health issue in Sri Lanka, and you as primary care physicians have an important role in overcoming this problem. So remember that you should not use, move on please, no steroids, adequate and proper treatment with oral and topical antifungals, proper patient education, and timely referral. Thank you. Next slide. I'm so sorry for the, yeah, not that one, please. I'm so sorry for the disturbances occurred, which was actually out of my control. So hope you were able to grasp something out of the lecture.
Right, thank you very much, madam, for that informative and very interesting presentation. I think you very correctly touched all the areas of this important infection, and I think now we can go ahead with the post-presentation feedback questions. Ladies and gentlemen, there will be a link that will be posted on your chat box. And just click that link and you'll be seeing a few questions which is based on this presentation. So you can then answer those questions. We'll be giving some time. In the meantime, you can also post your questions, the burning questions, to be answered by Dr. Lion Singh. So just click the link and first answer the questions. It's very important to see the response that we get from you.
Hello.
Okay, madam. Let me ask the first question from the Q&A. Okay, one participant has asked glycerin only available as 500 milligram tablets. So how to give in pediatric? So how to give glycerin as a pediatric dose?
Yes. So that is actually a problem that we have with all the antifungal drugs, not only glucophilin, even itraconazole and terbinafine. We don't have the oral suspensions, so it's difficult to give the proper dosages in children. I mean, very small children.
Right, the next question, madam. First, there are two parts. One is Tinea infections common in pregnancy, and how to treat them in pregnancy?
Why is Tinea infection common in pregnancy? That may be due to the hormonal changes and the immunity level decreasing. And how to treat, again, is going to be a challenging condition, because people are also worried because of the risk of infection to the child. But we have to first, especially if it is in the first trimester, we have to manage only with topical antifungal. And like terbinafine is a type B pregnancy category drug. So if the indication is much needed, we can weigh the risk and give terbinafine in second and third trimesters of pregnancy. It is a type category B drug in pregnancy.
Right. Okay. Another question. Apart from liver function test, LFTs, what other tests need to be done when patient needs an oral antifungal? The question can be probably broken into two small questions. One is there a need to do frequent or common tests for oral antifungal? If they are, if so, what is other thing other than the LFT?
Yeah, it's mainly the liver function test, and if the patient is having heart failure, we have to be cautious in giving itraconazole. And other than liver functions, actually there are not many tests that we have to do. But only thing is, sometimes if they are having the other features of insulin resistance and obesity, and if we think that we have to give the drug for a longer period, then there is always an indication for an ultrasound scan, because fatty liver is not so uncommon.
Okay, other question, I think certain questions have been already answered. I have another question saying, is there any effect of using salicylic acid and coal tar soaps? Madam, I think you are unmuted. You are muted, I think. Yeah.
Sorry, salicylic acid and coal tar soap.
Yes, is there any use of them?
Not really when it is in the soap form, but salicylic acid is a keratolytic agent. So we can use that to increase the drug penetration, and also it will give rise to effective fungal clearance. So that is actually an adjuvant treatment in the treatment of dermatosis. There's salicylic acid as well as this Whitfield ointment. Both of them can be used as adjuvant treatment. But since we have mentioned about the soap, I will just add some few words about this. Commonly, there are so many antifungal soaps which are available. Actually, these are not indicated in treating fungal infections.
And also there's a question, what is the difference between yeast infection and dermatophytes? Yeast and dermatophytes, and what about the treatment as well? I think this is something extra to this, but anyway, yeast and dermatophytes. I cannot hear Dr. Naini. Madam, you are not heard.
My mic is on.
All right, I think now we can hear you.
Okay. Yes. Yes, it's the candida infection that we have to talk about, and flu control is can be used when you are treating with for candidiasis, and that again will depend on the site of the infection, like the duration and the duration. And I will also test on this onychomycosis. Again, I need to in Sri Lanka because in Western literature, onychomycosis is mostly caused by dermatophytes. But in Sri Lanka, we have seen that it is mostly non-dermatophyte. It's not yeast. Yeast is taken as a commensal. It's non-dermatophyte. So in that case, the therapeutic response is even more low.
Right. You have clearly indicated that resistant tinea and probably long-standing tinea should be referred. But anyway, for interest sake, can you tell us, this is a question asked as I told you before as well, what are the drugs that have been used?
What are the drugs?
Sorry.
Yes. So actually, again, there are no hard and fast rules, and like even the recent Indian guidelines, they have just like listed out what is being practiced. So it should be like higher dosages of terbinafine given. And then isocontrol, actually they don't recommend for the usage of more than 200 milligrams. But there are instances that it is being used, and then like giving the drugs for longer duration. Combinations of oral antifungals, again, in practice, but then without much evidence. So actually, I know, like although I said to refer, like from that point onwards, it is like there are no hard and fast and no solid evidence as to how we can treat the chronic and recurrent dermatitis. It all depends on the personal experience and preferences.
Right, thank you, madam. And let's see whether we have more questions. One question is, the two questions are there actually, both asking what are some topical antifungals. And you already answered the question in the presentation, but just to reiterate, what are the topical antifungals that could be used?
Yes, you have the, like I mentioned, ACE, terbinafine, and the other medications like nursing and cyclopyra. And some of these actually have an anti-inflammatory action as well. Like things like cyclopyra, we have an anti-inflammatory action. So adding that kind of topical antifungal will actually improve the symptomatic control without adding a topical steroid. We are giving that to reduce the inflammation. And also the other thing is, it is always better to combine the topical antifungal and the oral antifungal from two different classes, because that might reduce the resistance from developing.
Right, thank you, madam. And actually, I have a question. This is about the terbinafine. When we are prescribing the terbinafine, the most important thing, as you were also mentioning in the presentation, is the cost. usually 1 250 milligram tablet of terbinafine is about around 100 rupees at least, 95, 100, in this range. Most of the patients come to us, and not only us, you also, they are not financially sound. So, can the College of Dermatologists locate the government or the pharmaceutical companies, from the NMRA, to reduce the prices of the antifungals, because as these, because fluconazole and so on are not very, as very correctly mentioned, not effective. In that sense, so we have to, I think, go with the, at least it's in the field most of the time, so others are also. So what about that?
Yes, I think you're asking impossible questions. The thing is, like, from the College of Dermatologists, we have requested ministry so many times, at least to have a continuous supply of itraconazole and to make terbinafine available in the government sector, which has also not yet happened. So I
Madam, I think you have one muted. Can't hear you.
Yeah, there was a problem with that. I think now you can hear me.
Yeah. Yeah.
Yeah. So I don't think price control is beyond our purview as a college.
Yeah, but I'm sure that you have achieved a lot by banning the triple combination.
And the triple combination was one of our highest achievements.
Yes, good. Yeah, most of these so-called high-priced drugs could be reduced to some level by, I think, competitive bidding and all. I think these are up to the usually up to the government, but I think College of Dermatologists can play a very good role. I think that's why I was asking.
You have to first have the other things like a continuous supply in the government sector.
Exactly. That is all. I think that is very important. Continuous supply in the government sector at least. Yeah. Okay. I think with that we don't have more questions. So thank you very much, madam, for this very productive discussion. And I think also the words of wisdom. And I thank you and also Dr. Chandra, the President of Sri Lanka College of Dermatologists, for this important webinar, being resource persons and having that continuous support to organize this, and also to Glenmark, who were behind this and supporting to organize this. So with that, let me hand over the floor to Prabhat Bandara from Glenmark to give the word of thanks. Prabhat, over to you.
Thank you very much, Doctor. Good evening, dear doctors. First of all, I take this point on behalf of Glenmark Sri Lanka to thank Sri Lanka College of Dermatologists and College of General Practitioners Association of Sri Lanka for giving us this opportunity to be the partner for today's meeting. We have witnessed today a very insightful lecture by Dr. Mrs. Naini Madrasinghe. Dear Madam, thank you very much indeed for your efforts and preparing and delivering the lecture today. And also let me thank Dr. Sankar Andenikumara for moderating the session on behalf of the General Practitioner Association of Sri Lanka. Let me also thank all the members of Sri Lanka College of Dermatologists and General Practitioners Association of Sri Lanka and other respective medical professionals who have participated in the webinar today by devoting their precious time. We will be informing the other sessions to be conducted in near future. Thank you. Thank you very much and good evening.